Hello, my name is Haitham Mekkawi, and today our topic is the anesthetic management of a patient who is thyrotoxic and presenting for thyroid gland removal with a very large goitre. Let me put it this way. Imagine you are about to put someone to sleep, but their thyroid gland is not sleeping. It is doing a full Zumba class, dancing with adrenaline, noradrenaline, and a pinch of insanity. Now add a retrosternal goitre pressing on the trachea like it is trying to apply a necktie from the inside. In this situation, our patient may be calm on the outside, but her hormones are planning a riot. We need to assess, stabilize, and manage this metabolic hurricane before we even touch the laryngoscope. Let us dive into the storm one step at a time. Let's start with clinical case of a thyrotoxic patient undergoing thyroidectomy. She is 48 years old, with a 3-year history of goiter, diagnosed with Graves' disease, and now complaining of breathing difficulty when lying flat. She's on anti-thyroid medication, currently euthyroid, but her computed tomography scan shows tracheal narrowing. Her vocal cords are moving normally, but she is coming to surgery because the gland is pressing and pills are not working. This is your classic recipe for anesthetic vigilance. Today we begin by assessing the airway in a patient with retrosternal goitre. Even with normal thyroid levels, a goitre under the sternum can bend the trachea like a straw in a sandstorm. Evaluate vocal cord movement and use computed tomography to understand how far the gland has gone. A deviated or narrowed trachea is your early warning system. Do not ignore it. Thyrotoxicosis is not always screaming. Sometimes it is whispering. Look for clues: heat intolerance, tremor, insomnia, and weight loss that is not from a gym membership. On examination, check for warm extremities, fast heart rate, and hyperkinetic behavior. Listen carefully for a thyroid bruit. Your job is to uncover the secret life of the thyroid gland before it crashes the operating theater. Test before you cut. Essential investigations before thyroidectomy in a thyrotoxic patient. This is not just blood work. This is a security clearance for safe anesthesia. We check thyroid profile to confirm hormone levels. Complete blood count for anemia and platelets, electrolytes to catch calcium or sodium imbalances. And yes, electrocardiogram and echocardiography, because a hyperactive thyroid often leads to a very dramatic heart. No patient should enter the operating room without these clearances. Will the tube fit? Symptoms and signs of airway compression from a thyroid mass. A goiter that grows like a tree root behind the sternum can turn airway management into a horror movie. Ask about positional breathing difficulty. Check for stridor, hoarseness, and difficulty swallowing. On examination, look for limited neck movement, visible tracheal shift, and any sign of eye exposure from exophthalmos. This is your warning to plan carefully or prepare for a surgical airway. What lies beneath? Imaging to evaluate the goiter and its impact. Start with a chest radiograph to identify tracheal deviation or mediastinal extension. Then move to a computed tomography scan to measure the narrowest tracheal diameter. Do not forget to perform flexible fiber optic laryngoscopy to assess vocal cord movement. These tools are your GPS. Without them, you are driving blind in airway. Even if the patient smiles and says she feels fine, her thyroid may still be plotting your downfall. Continue anti-thyroid medications, titrate beta blockers to reduce heart rate below 85 beats per minute, and correct electrolyte imbalances. Optional tools include Lugol's iodine to shrink the gland and steroids if the eyes are involved or the storm is near. Do not rush to the operating room. Control the gland first. Do not steer the storm. Induction and intubation for thyroidectomy. This is where calm hands and calm hormones meet. Blunt the sympathetic response with fentanyl, lidocaine, or esmolol. Use a standard intravenous induction agent, but remember to use rocuronium to avoid residual blockade. Choose an armored endotracheal tube and secure it like your life depends on it, because it might. Position the patient with a sandbag under the shoulders, neck extended, head tilted up, and arms tucked. This is a surgical ballet. Balance is everything. Eyes on the field, ears on the nerves. Intraoperative monitoring and surgical complications. Standard monitoring is essential. But if the goitre is large or the patient is unstable, insert an arterial line. Consider a nerve integrity monitor tube to protect the recurrent laryngeal nerve. Be vigilant for blood loss, especially with vascular glands. Watch for trachomalacia if the trachea was compressed for too long. And finally, beware the recurrent laryngeal nerve. Damage to one side causes hoarseness. Damage to both sides causes panic. The real work begins after. Postoperative care following thyroid gland removal. Extubate only when the patient is awake, calm, and after confirming vocal cord movement. Keep a clip remover at the bedside because a hematoma in the neck is not a joke. Monitor calcium levels at 6, 12, and 24 hours. Hypocalcaemia does not knock on the door, it crashes the party. Control pain, continue beta blockers, and keep fluid balance tight. Too much fluid, and you may find yourself rain tubating a swollen trachea. Storm warning, thyroid storm, the most feared complication of thyroid surgery. It usually strikes 6 to 24 hours after surgery, but sometimes sneaks in during the operation. Look for high fever, fast heart rate, atrial fibrillation, agitation, vomiting, and low blood pressure. It is not malignant hypothermia because there is no muscle rigidity or raised creatine kinase. Treat with propylthiouracil. Iodide after that, steroids, propranolol, and fluids. Do not forget cooling and never use aspirin. Admit to the intensive care unit early. This storm is not for amateurs.
Before ending the case, remember the pearls. Ensure the patient is euthyroid. Check the airway and vocal cords. Prepare for bleeding and low calcium. Watch for thyroid storm. Start hormone replacement if needed. Thyroidectomy is metabolic surgery. Avoid aspirin. Step carefully.